Thank you very much for the introduction and sharing my slides. Okay, let me know if you can see them.
Yes.
Okay, can you see them?
Yes.
All right. So, okay. Good morning, everyone. For those of you that are in the United States, here it's almost night in Italy, and today I'm presenting a work called Randomized Control Trials, claiming personalized, individualized, and precision interventions, characteristic, transparency, and bias. I am Luigi Russo. I'm a medical doctor, and I'm based in Rome, and this work started in 2022 when I was visiting research in Stanford University, and we just submitted the first version yesterday. So it came to a conclusion after almost 3 or 4 years of hard work. So we start from the promise and reality of personalized medicine. Basically, the challenge of the terms like personalized, individualized, and precision is that they are increasingly used to describe medical interventions, yet their operational meaning remains unclear. And the gap we found is that despite extensive conceptual debate, there is no empirical work, or at least there wasn't, that examined how these terms are applied in randomized controlled trials. So the objective of our research was to map the terminology. So we survey randomized controlled trials that used personalized, individualized, or precision in titles to understand how these terms are applied across clinical contexts. Moreover, we analyze trial characteristics, intervention features, and tailoring, and also we assess the quality, both in terms of transparency and also in the risk of bias. So, regarding the study design, as I was saying, we searched Medline for randomized control trial published between 2020 and 2022 in English. The protocol was pre-registered on Open Science Framework, and also all the data generated have been published online ahead of publication on Open Science Framework. And if you want, you can scan the QR code and see the project page. So as you can see, the search scheme was really simple and included the relevant terms in the title and filtered for randomized control trials. We included any randomized control trials with any design, so also cluster randomized trials, crossover design, and also included the protocols and trials with results. We excluded trials that employed the personalized in non-randomized intervention or that were used for non-medical conditions or non-health related. Regarding the data collection and variables, we extracted a lot of trial characteristics. In particular, we extracted the abstract conclusion, if there was favorable, mixed, or unfavorable towards the personalized intervention. We extracted the intervention features that I will present shortly, and also the transparency measures. In particular, we conducted an assessment based on human reviewer and also ran through the R transparent algorithm. But basically, we extract the data sharing and code availability, the registration on a trial repository, and also the timing of registration. This was done only manual. Funding statement and conflict of interest statement presence. Moreover, we did the risk of bias assessment using the ROB2 and developed by Cochrane, and we used the Roboto2 web app to conduct it. So, as you can see, we had a lot of types of intervention classified. So basically the personalized intervention could be digital, omics-based, behavioral, dietary, medication, surgery, anesthesia, rehabilitation, psychological. But moreover, we also extracted if in the intervention arm, there was a difference in the administration of such intervention. This difference, we classified it as difference in schedule or dosage of therapy, in the number of follow-up visits, in different testing, in the different drug used, or different anatomical target. For dosage and schedule of therapy, we considered not only pharmacological treatments, but also any other type of intervention. To give you an example, if we consider a physical exercise protocol, for example, we consider a different dosage if to an individual it was given, for example, 3 hours a day, and to another 5 hours a day. So this was a difference in the dosage of the physical activity intervention. So we classified it as difference in dosage of therapy. Regarding the personalization features, we extracted and classified a lot of different individual features, including demographics, socioeconomic, anthropometrics, vital signs, tests on biological material, omics, imaging tools, genetic, disease classification, lifestyle and behavioral, lifetime risk, complex scores, psychological and physical or functional capacity. These are the features for which the intervention was individualized and was designed for each participant. So the characteristic of the individual. Regarding categorization of the intervention comparison, to analyze how interventions were compared, we defined two primary groups based on the nature of the control arm. So we had a group one, the personalized intervention was compared to a non-personalized intervention, and it was classified post hoc in two different categories. Group 1A, basically we had studies with two or more intervention arms, but only one was personalized, individualized, or precision. In Group 1B, studies featuring more than one personalized intervention or precision intervention arm, but still compared to a non-personalized. The Group 2 compared only personalized versus other personalized interventions. Moreover, we categorized also the personalized intervention in a more granular way. Basically, what we did was to classify it by three categories: the number of personalized intervention. We classified the quantity of interventions within each study as 1, 2, 3, 4, or multiple, so more than 4, to understand the complexity of the trial design. Moreover, we analyzed the tailoring, so the specific ways interventions was adapted to participants, and it was categorized as 1, 2, 3, 4, multiple, or even for different for each patient. And we capture the degree of individualization. Moreover, for trials involving dosage differences, we extracted also the number of distinct dosage level, so 1, 2, 3, 4, multiple, or for each patient. And also for those that don't involve the dosage difference, we noted no dose involved. For the data analysis, we used obviously descriptive statistics for trial characteristics, and we classified studies on the basis of the combination of the number of interventions, the method of tailoring, and the number of different doses if available. For the statistical analysis, we conduct exploratory analysis for characteristics and for difference in characteristics and features based on the protocol versus trials with results, the term used, and also the abstract conclusion of the trial. To Fisher exact test and person chi-square. Regarding the transparency and human extraction of transparency indicators, we used Cohen's kappa for to assess agreement, and any discrepancy was reviewed for correct classification. So, regarding the results, we had 435 records identified and screened by title and abstract. Of these, 313 were sought for retrieval, and 262 were finally included in the study. Of these, 235 were randomized controlled trials with results, 27 were protocols, and 136 was the median of the sample size. As you can see, the terminology was unbalanced. We had mostly personalized and individualized terminology, respectively 49.2 and 45.8%, while precision was relatively uncommon, only the 5% and only 13 randomized controlled trials. For the geographic distribution of the papers, most of them were in Europe or in the United States, but also in China and in Australia. And the other regions include all over the world, from Africa to Asia. For the medical specialty represented, we had diverse applications. So cardiology, psychiatry, oncology, and endocrinology were the leading specialty, but also, as you can see, we had a vast number of the medical specialty with 72 additional trials that covered various other specialties, includes also occupational medicine, geriatrics, neurology, and many others. For the trial structure, as you can see on the left, we had most of the trials were two-arm trials, the 84%, and also most of them were Group 1A. So most trials basically were two arms and compared the personalized intervention administered in only one arm versus non-personalized control groups. The other classification were more rare. Regarding the abstract conclusion, they were overwhelmingly favorable. 70.6% were in favor, and 16.3% were mixed. Basically, we had like 87% the conclusion that were in favor, or at least not in favor towards the personalized interventions, and only the 13% was unfavorable. Regarding the application was mostly therapeutic in 186 trials, primary prevention in 74, and only 2 regarded secondary prevention. So, diving in the characteristic of the personalized interventions. So here there are the most frequent behavioral interventions were the most frequent, 33%, followed by digital interventions in the 29%, and also in medication-based interventions in 27.5%, and finally psychological in 21.8%. If we can, here we can see all the whole distribution of all the interventions types, and as we can see, also physical exercise, dietary education were quite common. Omics, as you can see, was present only in 6 trials, 2.3% of the trials. Regarding the individual features used for personalization, also here we can see lifestyle and behavior characteristic of the individual was the most frequent, 37.4%, followed by the disease classification. So in 75 trials, intervention were personalized on the characteristic of the disease of the participant. Also, we had interventions featured on the psychological traits in 27%, and also on vital signs in 21.4%. Also here you can see the whole distribution. We had 573 individual features identified. Each study could have more than one individual feature and more than one category of personalized intervention. And as you can see here, we have also physical or functional capacity, anthropometrics, or test on biological matter that were also quite common. And also here you can see on the right, genetic and omics only present in 13 and 8 trials. Regarding the subcategories of the specific of the personalization, you can see that most common features were patient preferences that fall under psychological traits, and also weight measurements and blood tests. While the rare features were the omics and genetics, so genetic testing, metabolomics, nutrigenomics, and polygenic or genetic risk scores. So, which were the difference within the interventions arm? Basically, personalization of the intervention relied mostly on different dosage or schedule of therapy administration. 136 studies had a difference in dosage of therapy, while 75 on schedule of therapy. Also here, you can the sum is not 262 because each trial could have more categories and more difference within the intervention arm. So I think this slide is really interesting because it shows that basically most studies employed either a single intervention. On the second row, you can see 67%, 177 trials implemented only one personalized intervention. Also, the tailoring was basically different for each participant in 82.8% of the trials, and also for those that at the dosage involved, the 73% had a dosage for different for each participant. The other cases, as you can see, were less common, and we are about 16 to 10%. So the most common personalization combination were 2 patterns. Pattern 1, single intervention and dose and tailoring individualized for each patient, or pattern 2, single intervention, tailoring different for each patient, no dose involved. And they represented also nearly 2/3 of all the trials, indicating that personalization involves, at least in our sample, adjusting a single interventions to the context or to the individual characteristics. The transparency patterns, now we changed a little bit the subject. We did this assessment of transparency and bias. So basically in our sample, the transparency indicators were really different for the finding a conflict of interest statement, as you can see on the left. Most of them were present in almost all the trials, 93.1, 93.5%, while data availability and code availability were really rare. Code availability only, open code availability only in one trial. For the open data, it was like the 5%, and if we consider also the data available upon request to the corresponding author, it was nearly the 30%, really low. On the other hand, registration was in the middle. Trials were registered on a repository in most of the cases, 77%, even though there is room for improvement also in terms of timing of registration. Indeed, as you can see, most of the trials were registered prospectively, 155, the 76% of the registered trials, and 25 before completion, while only 22 were registered retrospectively. 2 were not known since the registration code did give back any information. For the automated with manual assessment for the human reviewer and error transparent, I think this is also interesting to notice how error transparent perform in contrast to the human reviewer. So for funding declaration and conflict of interest declaration, error transparent performed better. So out of 21 and 11 conflicts, it was the vast majority. It was error transparent that was right. For data availability, it is 50-50, almost 50-50, while for study registration, we can see that human reviewer performed better. This is probably related to the fact that error transparent did not perform well in extracting data from the registry, like the Australian registry, New Zealand registry, or even Chinese repository for clinical trials. Regarding the risk of bias, you can notice that most of the trials were at a high risk, so 68%, or as we had some concerns, 13%. Only 42 studies, the 17% of the whole sample, had low risk of bias. And also, when we analyze the risk of bias across each domain, we can see that most of the high risk bias is caused by high risk in D5, so measurement of the outcome, or D4. D5 selection of the results, of the reported results, and D4 measurement of the outcome, that were the responsible for the high risk bias for most of the trials. Moreover, we conducted an exploratory analysis also to examine if there was differences in terms of risk of bias and favorable conclusion. As you can see, the distribution is really balanced across all the risk of bias domains, and the p-value is not significant. Finally, we conducted an association analysis for almost all the clinical trials features and characteristics, and stratified in terms for term employed, study design, or the conclusion of the abstract. And basically, few differences were found, and they were found only in the type of interventions. We found that digital and behavioral interventions were most likely to be termed personalized, and in terms of medication interventions, most commonly they were termed individualized. On the other hand, regarding the features of tailoring, we can see that lifestyle and behavioral factors were more commonly in personalized trials, where anthropometrics in individualized. Those are the only difference among the all analysis that we conduct, and also among the all type of interventions, features, differences that I showed you. So basically, they are used in the same way. So what we can discuss about our results in our article. First thing that I noticed working in personalized and precision medicine is the genomic gap. So my expectation was that most of the interventions should have been of genomics or genetic. Instead, genetic and genomic features were really rare, only 5 and 3.1% of the trials. And also they were really, they were rare, and they were also different than the dominant narratives that there is actually in the precision medicine discourse. This also may reflect that the discipline of personalized and precision medicine is shifting towards an integrative approach that incorporates also lifestyle, environmental exposure, and education, instead of focusing on genetic and genomics as it was in the first years of the 2010. The other thing that we noticed, and I think this is a key finding, is that personalization most often involved adjusting the intervention content, intensity, or dosage. The interventions, so they were heterogeneous in their application, but fundamentally the same in the structure, design, or conceptual framework. And also, the predominance of single interventions tailored to each participant suggests that this personalization is more a flexible delivery than a distinct therapeutical strategy. And the intervention basically remains the same, but is adapted to individual characteristics. Also, the other key finding, I think, in my opinion, is that despite frequent conceptual distinction in the literature, you can find a lot of definition for personalized precision and a lot of discourse on these things. These labels were applied largely interchangeably across trials. There was no difference. Also, what we notice is that the personalized targets, maybe they could also benefit, in particular for studies involving rehabilitation or physical exercise interventions, moving beyond rigid programs that may help overcome classical limitation. For example, fixed thresholds for all participants that are not taken into account the baseline characteristics. On the other hand, personalized approach could benefit the patient in guaranteeing a greater adherence to the intervention, improving the health outcomes, enhancing preventive effects. So personalized approaches could result in greater overall health benefit. However, as also we noticed in our paper, methodological challenge must be taken into account. In fact, interpretability is one of the key factors in exam, because if we tailor and personalize these interventions extensively across participants, it's difficult to understand what drives the outcome. Also, the reproducibility. If there is no clear and clear protocols of how the personalized intervention are tailored, it is difficult to replicate such interventions. Finally, also causal attribution, because determining which specific component of the personalized interventions becomes problematic if there is no clear explanation. A critical issue of our sample of articles was the lack of transparency, in particular in data and in code sharing. And it is problematic in these studies because the interventions tailored this relies to individual decision rules, algorithms, or adaptive components. And those are central to the intervention itself. And if there is no clear description, this undermines the value of the research itself. Also, we notice some biases, in particular in the terms of selective reporting and in terms also of outcome analysis. So this also must be addressed in future research. So how can we improve research in personalized medicine? We can enhance data sharing, so implement data and sharing policies for trials, improve the documentation of the intervention. We can also add, as a suggestion, more description, more detailed description, supplementary materials that describe precisely how these interventions are administered. Also strengthen the pre-registration that was really high at 77%, but could be better, and also address the bias and methodological limitations. The limitations of our work, some of this work has some limitations indeed, in particular for the search strategy restriction. Of course, some studies could use some individualized or personalized approach that, and they did not include it in the title. However, we think that the most important trials in the field should include it in the title, and also we have a representative sample. We had a few precision randomized control trials that use the term precision, and this restricts, of course, the generalizability of these findings. And finally, the terminology scope, because we focus on these tricky terms, but of course, we know that if, for example, in oncology, we use a variety of terms, for example, target therapy, master protocols, basket design, adaptive designs, and those were not captured. To conclude, contemporary randomized control trial that use personalized, individualized, or precision encompass a wide and heterogeneous set of interventions, most of them relying on lifestyle and behavioral approaches rather than genomics. And these terms are used largely interchangeably in practice. The fact that most trials reach favorable conclusion despite low transparency and high risk of bias suggests room for improving the rigor and reliability. The path forward is to enhance rigor, transparency, and methodological standard to improve personalized medicine research. And I thank you very much for the attention. And the preprint of this article, unfortunately, is not yet available. It's been approved in these days on Medrixi, but I think you can find it if you write down the title of the paper. And for any question, here is my email and contact. Thank you very much.